Biliary system. Welcome to today's podcast, where we discuss the main aspects of biliary system. Our conversation is structured in a question and answer format to support medical students, surgical residents, clinicians, and all listeners interested in the surgical management of the biliary system. Pause the podcast after each question to attempt answer. Let's begin. Anatomy and physiology question. How common are variations in biliary anatomy and vascular structures within the hepatoduodenal ligament? Answer. Anatomic variations in biliary anatomy and vascular structures in the hepatoduodenal ligament are common, occurring in up to 30% of patients. Question. Why is it important to understand both normal and variant anatomy of the biliary tract? Answer. Optimal management of patients with biliary tract diseases depends on a thorough understanding of both normal anatomy and common variations. Question. Where is the common bile duct located in relation to the hepatic arteries and portal vein? Answer. The common bile duct lies anterior to the hepatic arteries and portal vein in the duodenohepatic ligament. Question. Where is the biliary bifurcation located? Answer. The biliary bifurcation is located at the hilum, superior to the intrahepatic branches of the portal vein and hepatic arteries. Question. What are the principal right hepatic duct systems and how do they join? Answer. There are two principal right hepatic duct systems, right anterior and right posterior, which join to form the main right hepatic duct, with variations in their course and drainage patterns. Question. What is the location and size of the gallbladder? Answer. The gallbladder is a partially intraperitoneal structure attached to the liver, measuring 7 to 10 centimeters in length and holding 30 to 60 milliliters of bile. Question. How is the gallbladder structurally divided? Answer. The gallbladder is divided into neck, infundibulum, body, and fundus, with a fibrous lining called the cystic plate on the liver side. Question. How does bile drain from the gallbladder? Answer. Bile drains via the cystic duct, which is 1 to 5 centimeters long, into the common bile duct, with variations in the insertion point. Question. What is the definition of the common hepatic duct? Answer. The common hepatic duct is the segment of the extrahepatic bile duct below the biliary bifurcation and above the cystic duct insertion. Question. How is the common bile duct system practically divided? Answer. It is more practical to divide the common duct system into proximal, distal, and mid-common bile duct segments. Question. What is the course of the distal common bile duct? Answer. The distal common bile duct courses behind the first portion of the duodenum, enters a groove on the posterior surface of the superior pancreatic head, and joins the pancreatic duct in the ampulla. Vascular anatomy question. How is the hepatic parenchyma structurally organized? Answer. The hepatic parenchyma is divided into lobes and lobar segments, forming the basis for hepatic anatomic resections. Question. What is the blood supply of the biliary tree and what is its clinical significance? Answer. The biliary tree receives solely arterial blood supply, making it susceptible to ischemic injury. Question. Where does the cystic artery typically originate? Answer. The cystic artery typically arises from the right hepatic artery but can originate from various sources. Question. What is the usual anatomical position of the cystic artery? Answer. The cystic artery is generally superior to the cystic duct. Question. What is the calonode and when does it become enlarged? Answer. Calonode is a lymph node associated with the cystic artery, and it becomes enlarged in gallbladder disease. Question. What is the lymphatic drainage of the gallbladder? Answer. Calonode provides the lymphatic drainage of the gallbladder. Question. From which arteries do the common hepatic duct and common bile duct receive their blood supply? Answer. The common hepatic duct and common bile duct receive blood from the right hepatic and cystic arteries. Question. What is the pathway of the right hepatic artery in relation to the common hepatic duct? Answer. The right hepatic artery typically passes posterior to the common hepatic duct, supplies the right liver lobe, and crosses the duct within the triangle of Calot. Question. Where does the cystic artery branch from and why is this area vulnerable during surgery? Answer. The cystic artery branches from the right hepatic artery within the triangle of Calot, making this area vulnerable to injury during cholecystectomy. Question. What is the prevalence of hepatic artery anomalies in the population? Answer. 20% of the population has an accessory or replaced right hepatic artery. Question. Where does the accessory right hepatic artery pass? Answer. It passes through the portacaval space, ascending to the right lobe along the posterior and right lateral aspect of the common bile duct. Question. How can an accessory or replaced right hepatic artery be identified? Answer. It can be identified by a palpable pulse during the Pringle maneuver or seen on computed tomography scan as a vessel between the portal vein and inferior vena cava. Question. What are the tributaries contributing to the blood supply of the biliary system? Answer. Tributaries of the posterior-superior pancreaticoduodenal and gastroduodenal arteries contribute to the blood supply. Question. How many vessels run along the common bile duct and where are they positioned? Answer. There are 2 vessels running along the common bile duct at the 3 and 9 o'clock positions. Question. What is the surgical risk associated with dissection of areolar tissue surrounding the bile duct? Answer. Close dissection of the areolar tissue surrounding the bile duct can damage these vessels, leading to ischemic injury. Physiology question. What is the functional unit of the liver? Answer. The functional unit of the liver is the hepatic lobule, centered around a terminal hepatic venule. Question. How are bile salts produced and transported in the liver? Answer. Hepatocytes secrete bile salts into canaliculi, which drain into bile ducts. Question. How are most bile salts recycled? Answer. Most bile salts are recycled via enterohepatic circulation. Question. How is bile secreted from hepatocytes? Answer. Bile is secreted directly from hepatocytes into canaliculi. Question. What drives the flow of bile in the biliary tree? Answer. Bile flow is an osmotic process driven by the secretion of bile components, particularly cations, into the biliary tree. Question. How does bile maintain its osmolality relative to plasma? Answer. Bile maintains an osmolality similar to plasma due to the balance of cations and anions. Question. How are bile acids recycled in the body? Answer. Bile acids are reabsorbed in the ileum, transported to the liver, and recycled. Question. What is the rate-limiting step in bile salt excretion? Answer. Bile salts are transported across the canalicular membrane, which is the rate-limiting step in bile salt excretion. Question. How much of the bile salts are lost daily and what happens if there is an excess in the colon? Answer. Less than 5% of bile salts are lost daily in the stool, and excess bile salts in the colon can cause inflammation and diarrhea. Question. What are the main components of bile? Answer. Bile contains bile salts, proteins, lipids including phospholipids and cholesterol, and pigments. Question. What is the origin of cholesterol in bile and its significance? Answer. Cholesterol in bile comes from circulating lipoproteins and hepatic synthesis, and its secretion helps excrete cholesterol from the body. Question. What protective role do lipids have in bile? Answer. Phospholipids and cholesterol in bile protect liver cells from bile's toxicity. Question. What is the function of bile secretion? Answer. Bile secretion excretes toxins and metabolites from the liver. Question. What is the origin of bile pigments? Answer. Bile pigments are breakdown products of hemoglobin and myoglobin. Question. How are bile pigments metabolized and excreted? Answer. Bile pigments are conjugated to bilirubin glucuronides in hepatocytes and excreted in bile. Question. What factors regulate bile flow? Answer. Neural, humoral, and chemical stimuli, including vagal activity, secretin, and cholecystokinin, regulate bile flow. Question. What are the functions of the gallbladder? Answer. The gallbladder stores and concentrates bile, altering its composition and increasing the risk of cholesterol stone formation. Question. How does the gallbladder protect itself from the detergent activity of bile? Answer. Glycoproteins secreted by the gallbladder neck and cystic duct protect the gallbladder from bile's detergent activity and promote cholesterol crystallization. Question. What happens to the sphincter of Oddi during fasting? Answer. Increased activity of the sphincter of Oddi in the fasting state leads to increased pressure in the common bile duct and gallbladder filling. Question. How much bile can the gallbladder store daily? Answer. The gallbladder stores up to 300 milliliters of daily bile production. Question. What regulates the activity of the sphincter of Oddi and stimulates cholecystokinin secretion? Answer. Fat, protein, and acid in the duodenum inhibit sphincter of Oddi activity and stimulate cholecystokinin secretion. Question. What role does cholecystokinin play in gallbladder function? Answer. Cholecystokinin stimulates gallbladder contraction, increasing intraluminal pressure and promoting bile flow. Question. What is the influence of vagal activity on gallbladder emptying? Answer. Vagal activity induces gallbladder emptying but is less potent than cholecystokinin. Question. How does cholecystokinin-induced sphincter relaxation affect bile flow? Answer. Cholecystokinin-induced sphincter relaxation facilitates bile flow from the biliary tree, allowing for efficient gallbladder emptying. Diagnostic modalities laboratory tests question. Can any single laboratory test confirm or exclude the diagnosis of biliary disease? Answer. No single laboratory test can confirm or exclude a diagnosis. Question. Are laboratory studies important for both benign and cancerous biliary diseases? Answer. Laboratory studies are crucial for diagnosing and managing both benign and neoplastic pathologies. Question. Can laboratory test results, whether normal or abnormal, provide insight into disease processes? Answer. Both normal and abnormal laboratory results can provide insights into the underlying disease process. Complete blood count question. Should a complete blood count be performed in patients with suspected biliary disease? Answer. A complete blood count is recommended for patients being evaluated for biliary disease. Question. What does an elevated white blood cell count indicate in the context of biliary disease? Answer. Leukocytosis. An elevated white blood cell count is a systemic sign of inflammation and suggests a diagnosis of acute cholecystitis or cholangitis when seen with biliary obstruction. Question. What does a white blood cell count greater than 18,000 per cubic millimeter indicate in acute cholecystitis? Answer. A white blood cell count greater than 18,000 per cubic millimeter is classified as grade 2, or moderate, acute cholecystitis according to the 2018 Tokyo guidelines and indicates a worse prognosis. Hepatic function panel question. What aspects of liver and biliary function are evaluated by liver function tests? Answer. Liver function tests investigate metabolic and functional aspects of the liver and biliary system. Question. What are the causes of hyperbilirubinemia? Answer. Hyperbilirubinemia can be due to obstruction, which causes conjugated bilirubin, or due to increased synthesis, impaired uptake, or decreased conjugation, which results in unconjugated bilirubin. Question. Where is bilirubin elevation from obstruction first visible, and at what concentrations does it appear in the sclera and skin? Answer. Obstruction-caused elevation is first visible in the tongue frenulum, then in the sclera at 2.5 mg per deciliter, and finally in the skin at 5 mg per deciliter. Question. Can severe acute cholecystitis cause an elevation in total bilirubin? Answer. Severe acute cholecystitis can cause mild elevations of total bilirubin, less than 3 mg per deciliter, due to pericholecystic and periductal inflammation. Question. How can significant gallbladder distension affect the extrahepatic biliary ducts? Answer. Significant gallbladder distension can obstruct extrahepatic biliary ducts, leading to mild jaundice. Question. What are the most common causes of biliary obstruction? Answer. Cholelithiasis is the most common cause of biliary obstruction, but other possibilities include Mirizi syndrome, strictures, and malignancy. Question. What laboratory pattern is seen in cholestatic biliary disease? Answer. A cholestatic pattern is seen with elevated alkaline phosphatase with minimal alanine aminotransferase and aspartate aminotransferase elevation. Question. What does a hepatocellular pattern indicate on liver function testing? Answer. A hepatocellular pattern is indicated by elevated alanine aminotransferase and aspartate aminotransferase, which suggests hepatocyte damage. Question. Can significant alanine aminotransferase elevation occur in biliary obstruction? Answer. Significant alanine aminotransferase elevation can occur in cholelithiasis. Unique markers question. What is the role of gamma-glutamyl-transferase in biliary disease diagnosis? Answer. Gamma-glutamyl-transferase is a sensitive and specific test for cholelithiasis, with levels rising earlier and persisting longer in cholestatic diseases. Question. What is the significance of carbohydrate antigen 19-9 in biliary disease? Answer. Carbohydrate antigen 19-9 is a tumor marker used in diagnosing and prognostication of pancreaticobiliary malignancies, but can also be elevated in benign bile duct obstructions. Imaging studies plain films question. What is the significance of Rigler's triad on plain radiographs? Answer. Rigler's triad has been historically considered pathognomonic for gallstone ileus, but plain radiographs are limited in diagnosing biliary disease. Question. Are gallstones easily visible on plain radiographs? Answer. Gallstones are not regularly visible on plain radiographs, limiting their use in evaluating biliary disease. Question. What is the primary use of plain radiographs in abdominal diagnosis? Answer. Plain radiographs are primarily used to rule out other diagnoses like gastric or duodenal ulcers, small bowel obstruction, or pneumonia. Ultrasound question. What is the recommended first-choice imaging method for initial evaluation of jaundice and biliary disease? Answer. Transabdominal ultrasound is the recommended first-choice imaging method for initial evaluation. Question. What are the sensitivity and specificity of ultrasound for diagnosing acute cholecystitis? Answer. Although ultrasound has a high specificity and sensitivity for detecting gallstones, a meta-analysis revealed a sensitivity of 81% and specificity of 83% in the diagnosis of acute cholecystitis. Question. How effective is ultrasound in identifying gallstones? Answer. Ultrasound has high specificity and sensitivity for detecting gallstones, which appear as echogenic foci with shadowing. Question. How does ultrasound distinguish gallstones from gallbladder polyps or sludge? Answer. Gallstones move with positional changes, unlike polyps which are fixed or sludge which moves slowly. Question. What ultrasound findings suggest cholecystitis? Answer. Gallbladder wall thickening and pericholecystic fluid are visible by ultrasound and indicate cholecystitis. Question. What is Murphy's sign and how is it elicited? Answer. Murphy's sign is elicited during ultrasound examination by pressing the probe into the right upper quadrant during inspiration, causing cessation of inspiration. Question. Can ultrasound assess common bile duct dilation in jaundice? Answer. Ultrasound can assess common bile duct dilation in the setting of jaundice, which suggests obstruction of the duct. Computed tomography question. What are the advantages of computed tomography scan in biliary disease diagnosis? Answer. Computed tomography provides superior anatomic detail and is more sensitive than ultrasound in diagnosing cholecystitis, with sensitivity of 90% versus 80%. Question. What is a limitation of computed tomography scan in gallstone detection? Answer. Many gallstones are indistinguishable from bile due to being isodense on computed tomography scan. Question. What can computed tomography scan identify in patients with biliary disease? Answer. Computed tomography can identify the cause and site of biliary obstruction and detect ductal dilation in cholelithiasis. Question. When is a computed tomography scan strongly recommended in the evaluation of obstructive jaundice? Answer. Computed tomography scan is strongly recommended when malignancy is suspected in cases of obstructive jaundice to evaluate the liver and pancreas for potential tumors. Question. What is the importance of triple-phase computed tomography imaging? Answer. Triple-phase computed tomography imaging, including arterial, portal venous, and delayed phases, is crucial for preoperative planning in complex resections or reconstructions. Cholecystectomy question. What is the purpose of cholecystectomy in biliary disease? Answer. Cholecystectomy evaluates the physiologic secretion of bile. Question. How is cholecystectomy performed? Answer. Cholecystectomy involves injection of a radiotracer, which is processed in the liver and secreted into the biliary tree. Question. What does failure of the radiotracer to fill the gallbladder after 2 hours indicate on cholecystectomy? Answer. Failure of the radiotracer to fill the gallbladder after 2 hours indicates cystic duct obstruction, suggesting acute cholecystitis. Question. What is the diagnostic accuracy of cholecystectomy? Answer. Cholecystectomy is highly sensitive and specific for diagnosing acute cholecystitis. Question. What additional information can cholecystectomy provide? Answer. Cholecystectomy can confirm common bile duct patency and detect extraductal biliary leaks. Question. Can cholecystectomy be used to evaluate biliary dyskinesia? Answer. Cholecystectomy, with cholecystokinin stimulation, can assess gallbladder emptying and diagnose biliary dyskinesia. Magnetic resonance cholangiopancreatography question. What is magnetic resonance cholangiopancreatography? Answer. Magnetic resonance cholangiopancreatography is a non-invasive imaging technique used to visualize the biliary system and pancreas. Question. What are the advantages of magnetic resonance cholangiopancreatography compared to endoscopic retrograde cholangiopancreatography? Answer. Magnetic resonance cholangiopancreatography provides higher resolution images without ionizing radiation or invasive procedures, unlike endoscopic retrograde cholangiopancreatography. Question. What are the clinical applications of magnetic resonance cholangiopancreatography? Answer. Magnetic resonance cholangiopancreatography is useful for diagnosing cholelithiasis, Choledochal cysts, planning biliary or pancreatic neoplasm resection, and managing complex biliary disease. Endoscopic retrograde cholangiopancreatography question. What is the procedure of endoscopic retrograde cholangiopancreatography? Answer. Endoscopic retrograde cholangiopancreatography is an invasive test using endoscopy and fluoroscopy to image and treat the biliary tree. Question. What are the applications of endoscopic retrograde cholangiopancreatography? Answer. Endoscopic retrograde cholangiopancreatography diagnoses and treats biliary tree diseases, with a high stone clearance rate for cholelithiasis. Question. What is the complication rate of endoscopic retrograde cholangiopancreatography? Answer. Endoscopic retrograde cholangiopancreatography carries a complication rate of up to 10%. Question. How is endoscopic retrograde cholangiopancreatography used in the management of biliary duct injuries and malignant obstructions? Answer. Endoscopic retrograde cholangiopancreatography is used for non-surgical treatment of biliary duct injuries and malignant obstructions. Question. What is the use of biliary stents in endoscopic retrograde cholangiopancreatography? Answer. Biliary stents are deployed to divert flow from the injury or temporize the obstruction. Question. How can endoscopic retrograde cholangiopancreatography help in diagnosing malignant obstruction? Answer. Endoscopic retrograde cholangiopancreatography can provide tissue samples for diagnosis, and retrograde cholangioscopy can be used for further evaluation and biopsy. Endoscopic ultrasound question. For what is endoscopic ultrasound particularly valuable in the diagnosis of biliary disease? Answer. Endoscopic ultrasound is valuable for assessing the distal common bile duct and ampulla, particularly for the diagnosis of cholelithiasis. Question. What are the advantages of endoscopic ultrasound over other imaging modalities? Answer. Endoscopic ultrasound is highly sensitive and specific, capable of identifying small and distal stones not visible on other imaging modalities. Question. What types of ichondoscopes are used in endoscopic ultrasound and what are their uses? Answer. Radial ichondoscopes provide tomographic evaluation, while linear ichondoscopes guide interventions such as needle biopsies. Percutaneous transhepatic cholangiography question. What is percutaneous transhepatic cholangiography? Answer. Percutaneous transhepatic cholangiography is an invasive radiologic procedure used to evaluate the biliary tree. Question. What procedures can be facilitated by percutaneous transhepatic cholangiography? Answer. Percutaneous transhepatic cholangiography can facilitate insertion of transhepatic catheters for drainage, biopsy, or stone extraction. Question. In what clinical situations are endoscopic interventions preferred over percutaneous transhepatic cholangiography? Answer. In the setting of malignant obstruction and cholangitis, endoscopic interventions have improved outcomes. Fluorodeoxyglucose positron emission tomography question. What are the clinical applications of fluorodeoxyglucose positron emission tomography in biliary disease? Answer. Fluorodeoxyglucose positron emission tomography differentiates benign and malignant lesions, detects recurrence, and identifies metastatic disease. Question. What are the limitations of fluorodeoxyglucose positron emission tomography in diagnosing biliary tract neoplasms? Answer. Fluorodeoxyglucose positron emission tomography has a limited role in diagnosing biliary tract neoplasms due to the high background metabolic activity of the liver and potential for false positives. Question. How does fluorodeoxyglucose positron emission tomography work in detecting neoplasms? Answer. Fluorodeoxyglucose positron emission tomography uses a radiolabeled glucose molecule to exploit metabolic differences between highly metabolically active tissues, such as neoplasms, and normal tissue. Microbiology question. Is the biliary tree a sterile environment? Answer. The biliary tree is not a sterile environment due to insertion into the duodenum, but infection is rare without obstruction. Question. Where do bacteria found in the biliary system most likely originate? Answer. Bacteria in the biliary system likely originate from the upper enteric tract, similar to the duodenum's microbiota. Question. What are the most common bacteria found in the biliary system? Answer. Gram-negative bacteria such as Escherichia coli and Klebsiella are most common, followed by gram-positive Enterococcus. Question. Are biliary colic and cholelithiasis considered infectious diseases? Answer. Biliary colic and cholelithiasis are not infectious, but cholecystitis can involve a bacterial infection due to cystic duct obstruction and biliary stasis. Question: what antibiotic therapy is recommended for cholecystitis? Answer: recommended regimens for cholecystitis include coverage for gram-negative bacteria and anaerobes, such as piperacillin-tazobactam, or cephalosporin or fluoroquinolone with metronidazole for penicillin allergies. Question: when are antibiotics recommended for patients undergoing cholecystectomy according to the 2018 Tokyo Guidelines? Answer: the 2018 Tokyo Guidelines recommend antibiotics before and during cholecystectomy, but not after, as postoperative antibiotics do not improve outcomes. Benign biliary disease calculus biliary disease. Question: what is the prevalence of cholelithiasis in the population? Answer: cholelithiasis affects 10% to 15% of the population, making it the most common disease of the gallbladder and biliary tree. Question: how are gallstones primarily classified? Answer: gallstones are primarily classified into cholesterol stones, which make up over 70% in the United States, and pigment stones, which are black and brown. Question: what are the characteristics of black and brown pigment stones? Answer: black stones are associated with hemolytic conditions and are found in the gallbladder, whereas brown stones are linked to infections in the biliary tree and suggest biliary motility disorders. Question: how can the composition of bile contribute to gallstone formation? Answer: high cholesterol and lipid concentrations in bile secretion can lead to cholesterol stone formation. Question: how does bile concentration influence gallstone formation? Answer: water and sodium absorption in the gallbladder increases bile solute concentration, which promotes gallstone formation. Question: what role do bile salts play in gallstone formation? Answer: bile salts help dissolve cholesterol, thus influencing gallstone formation. Question: when does cholesterol precipitate into crystals within the gallbladder? Answer: cholesterol precipitates into crystals when its concentration in gallbladder vesicles surpasses its solubility. Question: what effect do chronic-leading agents have on gallstone formation? Answer: chronic-leading agents such as glycoproteins and immunoglobulins accelerate crystal formation. Question: how does abnormal gallbladder motility impact stone formation? Answer: abnormal gallbladder motility can increase the time for solutes to precipitate, leading to stone formation. Question: what conditions are associated with impaired gallbladder emptying? Answer: prolonged fasting, total parenteral nutrition, vagotomy, somatostatin analogs, and glucagon-like peptide-1 receptor agonists are associated with impaired gallbladder emptying. Question: how prevalent is cholelithiasis in the population? Answer: cholelithiasis affects 10% to 15% of the population, making it the most common disease of the gallbladder and biliary tree. Question: what is the primary classification of gallstones? Answer: gallstones are primarily classified into cholesterol stones, which make up over 70% in the United States, and pigment stones, which are black and brown. Question: how do pigment stones form and where are they typically found? Answer: black pigment stones form in the gallbladder due to hemolytic conditions, while brown pigment stones containing cholesterol develop in the bile ducts due to infection and biliary motility disorders. Natural history. Question: when do gallstones cause symptoms? Answer: gallstones cause symptoms when they obstruct a visceral structure, most commonly the cystic duct. Question: how are asymptomatic gallstones typically discovered? Answer: asymptomatic gallstones remain without symptoms and are often discovered incidentally during imaging. Question: is prophylactic cholecystectomy recommended for asymptomatic gallstones? Answer: prophylactic cholecystectomy is not recommended for asymptomatic gallstones due to the low risk of developing symptoms or complications. Question: who are considered high-risk patients for cholecystectomy? Answer: high-risk patients for cholecystectomy include those with hemolytic anemias, porcelain gallbladder, large gallstones, or diabetes. Question: why is cholecystectomy performed in high-risk patients? Answer: cholecystectomy is performed in high-risk patients due to a higher risk of pigment stone formation, cholecystitis, symptomatic disease, cancer conversion, or gangrene. Question: for whom is prophylactic cholecystectomy considered? Answer: prophylactic cholecystectomy is considered for certain high-risk patients to prevent complications. Question: Is prophylactic cholecystectomy routinely recommended during minimally invasive bariatric surgery? Answer: There is ongoing debate about the necessity of prophylactic cholecystectomy during minimally invasive bariatric surgery. Question: What is the general recommendation regarding prophylactic cholecystectomy? Answer: Prophylactic cholecystectomy is generally not recommended. Question: In which cases is prophylactic cholecystectomy considered safe and effective? Answer: Prophylactic cholecystectomy is considered safe and effective for high-risk patients or those experiencing biliary colic. Question: How does rapid weight loss affect the risk of stone formation? Answer: Rapid weight loss increases the risk of stone formation. Question: What challenges are encountered with stone removal after gastric bypass? Answer: Endoscopic retrograde cholangiopancreatography for common bile duct stone removal in ascending cholangitis can be difficult after gastric bypass. Question: How have management techniques for common bile duct stones improved? Answer: Laparoscopic and endoscopic techniques for common bile duct stone management have improved, increasing success rates. Non-operative treatment of cholelithiasis. Question: What are the limitations of medical treatment for gallstones? Answer: Medical treatment for gallstones is often unsuccessful, with high recurrence rates for dissolution strategies. Question: What are alternative treatment options to surgery for gallstones? Answer: Extracorporeal shockwave lithotripsy offers a lower recurrence rate for specific stone sizes, and newer modalities such as cystic duct embolization show promise for non-surgical candidates. Question: Why is laparoscopic cholecystectomy the preferred treatment for gallstones? Answer: The widespread use, safety, and efficacy of laparoscopic cholecystectomy have made it the preferred treatment, reserving non-surgical options for patients at high risk from general anesthesia. Chronic cholecystitis. Question: What causes chronic cholecystitis? Answer: Chronic cholecystitis is caused by recurrent biliary colic attacks leading to inflammation and scarring of the gallbladder neck and cystic duct. Question: How is chronic cholecystitis diagnosed in relation to biliary colic? Answer: Chronic cholecystitis lies along a continuum with biliary colic, as it results from recurrent attacks. Question: How does chronic cholecystitis typically present? Answer: Chronic cholecystitis typically presents as symptomatic cholelithiasis or biliary colic. Question: What triggers biliary colic pain? Answer: Biliary colic pain is triggered by pain after fatty meals due to increased cholecystokinin secretion in response to duodenal fat. Question: What are the characteristics of biliary colic pain? Answer: Biliary colic pain is epigastric or right upper quadrant pain, radiating to the scapula, and lasting a few hours. Question: What are the symptoms of acute cholecystitis? Answer: Symptoms of acute cholecystitis include pain lasting over 24 hours, fever, bloating, nausea, and vomiting. Question: What complications are associated with symptomatic gallstones? Answer: Symptomatic gallstones have a higher likelihood of complications such as acute cholecystitis, cholelithiasis, gallstone pancreatitis, and cholangitis. Question: What is the treatment for symptomatic cholelithiasis? Answer: The treatment for symptomatic cholelithiasis is cholecystectomy. Question: What is the most common indication for cholecystectomy? Answer: Documented stones and symptoms are the most common reasons for performing a cholecystectomy. Diagnosis. Question: What is the basis for diagnosing benign biliary disease? Answer: Diagnosis is based on a history consistent with biliary tract disease. Question: What findings on ultrasound suggest biliary disease? Answer: Ultrasound findings that suggest biliary disease include cholelithiasis, common bile duct dilation, gallbladder polyps, porcelain gallbladder, hepatic parenchymal processes, cholesterolosis, gallbladder sludge, or microlithiasis. Question: How is symptomatic cholelithiasis defined in terms of imaging findings? Answer: Symptomatic cholelithiasis is defined as gallbladder sludge or microlithiasis with appropriate symptoms. Treatment. Question: What treatment is recommended for symptomatic gallstones? Answer: Elective cholecystectomy is recommended for patients with sufficient symptoms. Question: What factors should be considered in the risk and benefit analysis of cholecystectomy? Answer: Cholecystectomy, while low risk, requires weighing potential complications against the benefits of symptom relief. Question: How should symptom severity guide the treatment of gallstone disease? Answer. Mild symptoms may be managed with observation and lifestyle changes, while severe or recurrent symptoms warrant elective laparoscopic cholecystectomy. Non-calculous biliary disease. Acute acalculous cholecystitis. Question. What is the definition of acute acalculous cholecystitis? Answer. Acute acalculous cholecystitis is defined as blockage of the cystic duct without gallstones. Question. What is the pathogenesis of acute acalculous cholecystitis? Answer. The pathogenesis of acute acalculous cholecystitis is poorly understood but is likely due to biliary stasis, distension, inflammation, and infection. Question. What are the risk factors for developing acute acalculous cholecystitis? Answer. Risk factors for acute acalculous cholecystitis include old age, burns, trauma, prolonged total parenteral nutrition, critical illness, immunosuppression, and diabetes. Question. How does acute acalculous cholecystitis present in critically ill patients? Answer. In critically ill patients, acute acalculous cholecystitis may lack classic symptoms such as right upper quadrant pain or fever. Question. What imaging findings suggest acute acalculous cholecystitis? Answer. Imaging findings such as pericholecystic fluid and gallbladder wall thickening should raise suspicion for acute acalculous cholecystitis. Question. What is the role of the HITA scan in acute acalculous cholecystitis? Answer. The HITA scan is diagnostic for acute acalculous cholecystitis, but it can yield false positive results. Question. What is the treatment for acute acalculous cholecystitis? Answer. Cholecystectomy is therapeutic for acute acalculous cholecystitis, but non-operative strategies are often required for critically ill patients. Question. In what patient population does acute acalculous cholecystitis most often occur? Answer. Acute acalculous cholecystitis often occurs in critically ill patients who cannot tolerate surgery. Question. What is a safer treatment option for draining the gallbladder in patients with acute cholecystitis who cannot undergo surgery? Answer. Percutaneous cholecystostomy tube placement is a safer option for draining the gallbladder in such patients. Question. What is the success rate of cholecystostomy tube placement in treating acute cholecystitis? Answer. More than 90% of patients improve with a cholecystostomy tube. Question. When is interval cholecystectomy necessary after initial non-operative management for acute cholecystitis? Answer. Interval cholecystectomy is necessary only if follow-up imaging continues to show positive findings. Question. What should be considered if a patient does not improve after percutaneous cholecystostomy tube placement for 24 hours? Answer. If a patient does not improve after 24 hours, exploration with cholecystectomy should be considered. Question. Why is cholecystectomy indicated in some patients with acute acalculous cholecystitis despite drainage? Answer. Cholecystectomy is indicated because patients are likely to have a perforated gallbladder, and drainage alone is insufficient. Biliary dyskinesia. Question. What is biliary dyskinesia? Answer. Biliary dyskinesia is a functional disorder of the biliary tree, generally defined by gallbladder dysmotility. Question. What symptoms are associated with biliary dyskinesia? Answer. Patients with biliary dyskinesia may have classic symptoms of biliary colic but lack ultrasonographic evidence of stones or sludge. They may also have vague symptoms, including nausea and oral intolerance. Question. How is biliary dyskinesia typically diagnosed? Answer. Biliary dyskinesia is usually a diagnosis of exclusion. Question. What makes the diagnosis of biliary dyskinesia challenging? Answer. Diagnosis is difficult because patients with functional gastrointestinal disorders often have other functional disorders. Question. What is the role of the Rome Foundation in biliary dyskinesia? Answer. The Rome Foundation developed diagnostic criteria to help diagnose and treat functional gastrointestinal disorders, including biliary dyskinesia. Question. What is the purpose of the diagnostic criteria for biliary dyskinesia? Answer. The criteria are used to rule out other frequent causes of symptoms, such as gastroesophageal reflux disease and inflammatory bowel syndrome. Question. What diagnostic tests can help in diagnosing biliary dyskinesia? Answer. Computed tomography, endoscopy, and cholecystography. Cholecystokinin-stimulated HITA scan can help diagnose biliary dyskinesia. Question. What finding on cholecystokinin-stimulated HITA scan suggests biliary dyskinesia? Answer. An ejection fraction less than 35% during a cholecystokinin-stimulated HITA scan suggests biliary dyskinesia. Question: what is the recommended treatment and prognosis for patients with biliary dyskinesia? Answer: cholecystectomy is beneficial for most patients, especially those with typical biliary colic and reduced ejection fraction. Endoscopic retrograde cholangiopancreatography with sphincterotomy may be useful for non-responders. Sphincter of Oddi dysfunction. Question: what is sphincter of Oddi dysfunction? Answer: sphincter of Oddi dysfunction is a rare disease characterized by a structurally or physiologically abnormal sphincter with higher tone and failure to relax. Question: what symptoms are seen in sphincter of Oddi dysfunction? Answer: symptoms include pain and recurrent pancreatitis with a usually normal liver function panel. Question: what are the risk factors for sphincter of Oddi dysfunction? Answer: chronic pancreatitis or calculus disease are risk factors as they can lead to fibrosis and subsequent sphincter dysfunction. Question: what is the etiology of sphincter of Oddi dysfunction? Answer: the disease is caused by failure of the sphincters to relax, leading to increased pressure in the biliary tree. Question: what are the subtypes of sphincter of Oddi dysfunction? Answer: subtypes include the biliary subtype, which presents with biliary colic symptoms, and the pancreatic subtype, which presents with recurrent pancreatitis. Question: how is sphincter of Oddi dysfunction diagnosed? Answer: it is suspected in patients with biliary pain and a common duct diameter over 12 mm, often using the Milwaukee classification. Question: what are the characteristics of type I sphincter of Oddi dysfunction? Answer: type I is characterized by typical pain, abnormal pancreatic or hepatic enzymes, and common bile duct dilation, and is most likely to respond to intervention. Question: what are the characteristics of type 2 sphincter of Oddi dysfunction? Answer: type 2 is characterized by pain and one other criterion, which could be abnormal enzymes or common bile duct dilation. Question: what defines type 3 sphincter of Oddi dysfunction? Answer: type 3 is defined by pain only and is least likely to respond to intervention. Question: what is the primary treatment for sphincter of Oddi dysfunction? Answer: endoscopic retrograde cholangiopancreatography with sphincterotomy is highly effective for sphincter of Oddi dysfunction. Question: what result on sphincter manometry supports a diagnosis of sphincter of Oddi dysfunction? Answer: A. Pressure greater than 40 mm of mercury during endoscopic retrograde cholangiopancreatography is consistent with sphincter of Oddi dysfunction. Question: what non-procedural interventions have been used for sphincter of Oddi dysfunction? Answer: nitrates and calcium channel blockers have been used with moderate success. Surgery for calculus biliary disease laparoscopic cholecystectomy. Question: what is one of the most commonly performed general surgery procedures in the United States? Answer: one of the most commonly performed general surgery procedures in the United States is laparoscopic cholecystectomy. Question: what is the mortality rate associated with laparoscopic cholecystectomy? Answer: the mortality rate associated with laparoscopic cholecystectomy ranges from 0.1% to 0.5%. Question: what is the morbidity rate for laparoscopic cholecystectomy? Answer: the morbidity rate for laparoscopic cholecystectomy is 2% to 3%. Question: what are the advantages of laparoscopic cholecystectomy compared to traditional open cholecystectomy? Answer: the advantages of laparoscopic cholecystectomy include smaller incisions, less pain, and shorter hospitalization compared to traditional open cholecystectomy. Question: how is laparoscopic cholecystectomy regarded for acute cholecystitis, and what are its potential challenges? Answer: laparoscopic cholecystectomy is considered the gold standard for acute cholecystitis but may involve longer operative times and a higher conversion rate to open surgery. Question: what are the contraindications for laparoscopic cholecystectomy? Answer: contraindications for laparoscopic cholecystectomy include inability to tolerate general anesthesia, end-stage liver disease with portal hypertension, and coagulopathy. Question: how should a patient be positioned for laparoscopic cholecystectomy? Answer: the patient should be positioned supine with one arm tucked, potentially allowing for intraoperative cholangiogram. Question: what preoperative preparations are necessary for laparoscopic cholecystectomy? Answer: preoperative preparations may include placement of a Foley catheter if needed, use of an orogastric tube for stomach decompression, and prepping draping to accommodate potential conversion to open procedure. Question: why should the patient be well secured during laparoscopic cholecystectomy? Answer: the patient should be well secured to accommodate steep reverse trend Ellenberg positioning during the procedure. Question: how many laparoscopic ports are used and what are their sizes in laparoscopic cholecystectomy? Answer: 4 laparoscopic ports are used. A 12 mm port near the umbilicus for specimen extraction and 3 5 mm or smaller ports for dissection. Question: where are the ports typically placed during laparoscopic cholecystectomy? Answer: the ports are placed in the right anterior axillary line, right midclavicular line, and subxiphoid location. Question: what is the modified French position, and how is it used in laparoscopic cholecystectomy? Answer: the modified French position involves split legs, with fundus retraction via a subxiphoid port and working ports in the left and right upper quadrants. Question: how is the gallbladder fundus managed during laparoscopic cholecystectomy? Answer: the gallbladder fundus is grasped and retracted cephalad to expose the infundibulum. Question: what is the purpose of retracting the infundibulum laterally in laparoscopic cholecystectomy? Answer: retracting the infundibulum laterally provides exposure for dissection of cystic structures. Question: how is the critical view of safety achieved during laparoscopic cholecystectomy? Answer: the critical view of safety is achieved by distracting the infundibulum or Hartmann pouch laterally with the surgeon's left operative instrument. Question: how are the cystic duct and artery identified during laparoscopic cholecystectomy? Answer: inferolateral traction of the infundibulum is applied while dissecting the fibrofatty tissue to identify the cystic duct and artery. Question: what is the anatomical landmark for the cystic artery during laparoscopic cholecystectomy? Answer: the callo node, a lymph node lying on top of the cystic artery, serves as the anatomical landmark for the cystic artery. Question: what are the criteria for confirming the critical view of safety during laparoscopic cholecystectomy? Answer: the critical view of safety is confirmed when 2 structures are seen entering the gallbladder, the lower third is dissected from the liver, and the hepatocystic triangle is cleared. Question: how is the gallbladder removed during laparoscopic cholecystectomy? Answer: clips are placed on the cystic artery and duct, which are then cut, and the gallbladder is separated from the liver using electrocautery. Question: why is achieving excellent hemostasis important during gallbladder dissection? Answer: achieving excellent hemostasis is crucial because the venous drainage is directly into the liver bed during gallbladder dissection. Question: what are the post-removal steps after gallbladder is excised in laparoscopic cholecystectomy? Answer: the gallbladder is removed through the umbilical port using a specimen retrieval bag, and any spilled stones are retrieved to prevent abscesses. Complications of cholecystectomy. Post-cholecystectomy syndromes. Question: what is post-cholecystectomy syndrome and how common is it after gallbladder removal? Answer: post-cholecystectomy syndrome is the recurrence of symptoms similar to those experienced before a cholecystectomy, and it occurs in 10 to 15% of all cholecystectomies. Question: when do symptoms of post-cholecystectomy syndrome typically appear and which demographic is more affected? Answer: symptoms may manifest from days to years after cholecystectomy and are more common in females. Question: what are the possible causes of post-cholecystectomy syndrome? Answer: causes range from surgical complications to primary unrelated etiologies such as esophagitis, gastroesophageal reflux disease, and biliary etiologies. Bile duct injury. Question: how common is bile duct injury during cholecystectomy procedures? Answer: more than 80% of bile duct injuries occur during cholecystectomy. Question: what are the risk factors for bile duct injury during cholecystectomy? Answer: risk factors include variable anatomy, inflammation, inappropriate exposure, inadequate experience or skill, and aggressive hemostasis. Question: which factor is more commonly associated with bile duct injury? Misperception of anatomy or surgical skill? Answer: misperception of the anatomy is a more common factor than surgical skill. Question: what is essential during cystic duct dissection to avoid injury to the common hepatic duct? Answer: inferolateral traction of the gallbladder infundibulum is required during cystic duct dissection to avoid injuring the common hepatic duct. Question: how is the critical view of safety achieved during laparoscopic cholecystectomy? Answer: the critical view of safety is achieved by retracting the Hartmann pouch inferolaterally, opening the triangle of Callo, and using a 30-degree laparoscope. Question: How are bile duct injuries often identified and what role does cholangiography play? Answer. Bile duct injuries are often identified postoperatively due to confirmation bias and can be reduced, but not completely avoided, by cholangiography. Question. What are the typical symptoms of bile duct injury? Answer. Symptoms include jaundice, with or without pain. Question. How often do postoperative bile duct strictures occur after cholecystectomy? Answer. Postoperative bile duct strictures occur in less than 1% of all cases. Question. How is bile duct injury classified and why is this important? Answer. Bile duct injury is classified by its location, which helps guide surgical reconstruction. Question. Who modified the bismuth classification for bile duct injury? Answer. The bismuth classification was modified by Strasberg. Question. On what is the original analysis of bile duct injury based? Answer. The original analysis is based on the bismuth classification. Question. What are the different types of bile duct strictures according to the classification system? Answer. E1 and E2 strictures involve the common hepatic duct but not the bifurcation. E3 occurs at the confluence. E4 includes the extrahepatic biliary tree. E5 involves aberrant right hepatic duct anatomy. Question. How do bile duct injuries typically present? Answer. They typically present with bile leakage or stricture. Question. What complications can arise from bile duct injury? Answer. Complications include bile leakage or stricture. Question. What are the symptoms of bile leakage following injury? Answer. Symptoms include fever, abdominal pain, jaundice, or bile leakage from the incision. Question. When are postoperative bile duct strictures most commonly diagnosed? Answer. Less than 10% are diagnosed within the first week, while over 70% are diagnosed within 6 months. That's it. Thanks for tuning in. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the Extraordinary.